Welcome back to my channel. Let us learn about external fixators today. These are the contents we'll dive into directly. Definition. If you remember the internal fixator, it was a surgical process where we are fixing either the plate or screw internally in order to reduce the fracture. But here, it is a surgical process that stabilizes and joins the ends of the fractured bone by externally placed mechanical devices. Lambert's principle is nothing but the same Lambert's principle of surgical treatment for fracture, anatomical reduction. Yes, open reduction or closed reduction, we need to do it. If it is open reduction, well and good. We are doing internal fixation or external fixation. Stable internal fixation, if it is not possible to attain the stability by internal fixation, thus we have to do the external fixation because external fixation gives us more stability compared to internal fixation. Preservation of blood supply, very important. Active pain-free mobilization of adjacent muscles and joints should be maintained after the surgery, for which collective decision should be taken by surgeon and a physiotherapist. Methods of applying: exposure of the fracture, reduction of the fracture, provisional stabilization, and definitive stabilization of the fracture. These are very important to follow in a surgery. Coming down to types of external fixator. Malgian fracture fixator. Developed by Malgian in 1843 to treat fracture of the kneecap and olecranon. If you remember, in internal fixator, to treat the patellar fracture, stellate patellar fracture and stellate olecranon fracture, there was a special technique known as tension band wiring. That was an internal fixator. Same principle is used in the case of external fixator by Malgian fixator. The mechanism was made up of clamp that approximated four transcutaneous metal prongs. So these are the prongs. You can see one, two, three, four. So this is just going to hold up the patella, and using the screw, the external screw, you're just going to tighten so that these once you tighten the screws, the prongs come closer to induce the compression force on the fractured bone, thus leading to healing. Sorry. The next one is Freeman fixator. Discovered by Freeman, the names are so easy to remember the technique. Discovered by Freeman, similar to that of Park-Hill technique, single pin, you can see that single pin was inserted above and below the fracture segment, which were connected to each other by a metal bar. So you can see the fracture line, single pin was inserted above, single pin was inserted below the fracture segment, which were connected by each other to each other by a metal bar covered in a wood. Now this is external, whereas the bone and the screws are going to be internal. This rod, whatever you're going to see, has to be external. He also affirmed that pins should be inserted at a certain distance away from the fracture site. So these pins should not be too close enough. If it is too close enough, it's just going to have a lot of compressive forces. Rather than healing, it will destroy the neurovascular tissues. And if it is too away, there's decreased compressive forces. Thus, it will not provide good amount of compression in order to heal the bone. Monolateral external fixator is just fixing on one side. Discovered by Clayton and Parkhill in 1897. Four screws, two inserted into each fragment above and below. Here it was just one on above, one on below. Here at monolateral it is two above, two below. Ends of the screws were fixed together by interlocking small plates and bolts. Useful in wrist and pediatric fracture as suggested by Professor Karev and Professor Mikhail Bisaccia. Sorry. Ketley fixator. You can see it is just like a Ketley. Developed by Ketley in 1839 to treat fracture of the kneecap and olecranon, same like malignant fracture. Rigid pins of stainless steel were inserted into the bone and connected to the external system. You can see the external system. It's just like your feet is into the kettle and inside the kettle, whereas the screws are outside. Rigid pins of stainless steel were inserted directly into the bone and connected to the external system. Two horizontal braces of splint with the main objective of reducing pseudoarthrosis. In Ketley fixator, the main objective is to reduce pseudoarthrosis. Last three, very important, are Anderson device with transfixation pins. You can see that there are two rods and the pins are transversely fixated. They are just parallel to each other. Discovered by Anderson, the system was made up of transfixing pins connected to the metal clamps. You can see that these are the metal clamps. Through and through trans-pin fixation device. Why it is known as through and through is just because they are sideways. From one side to other side, they are connected by a metal bar. So it is known as through and through. The fixator composed of metal plane reduction as well as compression. The next one is Lambert's external fixator. It's just on one side. It's not bilaterally like in Anderson's device with transfixation screws. Discovered by Lambert in 1902, unilateral frame consisting of metal pins. It's a unilateral frame consisting of metal pins that penetrated into the bone and protruded through skin in a systematic manner. You can see that it's just penetrating into the bone and protruding again to the through the skin. There's no skin, we have removed it just to make sure that you understand the diagram. The pins were connected to each other by an external device. You can see that this is a screw protruded through the bone one side. There is a metal rod and the pins are seen over here. So this here is going to be the skin. So the pins are also coming out of the skin. Elizaro's external fixator. This is very important, frequently seen, commonly done in orthopedic surgeries, especially for tibia, permits stabilization of high energy fracture with minimal operative trauma to soft tissue and preserving critical blood supply to the bone. Early use of limb, advancement to early weight bearing permitted and encouraged. Eliminates need of extensive soft tissue procedure and bone grafting. Salvage arthrodesis of knee, ankle and hide foot. Ilizarro pin to ring concept. Pin to ring concept will be discussed in the next video. It's very important because you can see that it's a ring, two rings placed on above, two rings placed below the fracture, and the rings are having the pins where the pins are inserted to the bone. Now, per day, this pin is tightened up for up to 1 millimeter to 2 millimeter, not exceeding 2 millimeter. This tightening will enhance the compression on either end, thus leading to healing of the fracture. Last slide, complications of external fixator, pin tract infection, very common, neurovascular impalement, not that common, muscle and tendon impalement, very common, delayed union, many times because of the patient and because of cosmetic reason, no weight bearing and delayed union, compartment syndrome, commonly seen, refracture, if it is a high velocity trauma, again on the same fracture with Ilizarro technique, yes, refracture is definitely seen. Advantages rigid fixation, compression, neutralization of fixed distraction, direct surveillance, immediate motion of proximal and distal joint is allowed, early patient mobilization is allowed, early weight bearing compared to internal fixation. Disadvantage meticulous pin insertion technique and skin and pin tract care are required to prevent pin tract infection. Pin and fixator frame can be mechanically difficult to assemble by uninitiated surgeon after the refracture again. Frame can be cumbersome and patient may reject due to aesthetic reason. Yes, because of which there is delayed union. Fracture through pin tract may occur, definitely seen. Refracture after frame removal may occur. Equipment is expensive. A non-compliant patient may disturb appliance and adjustment. Daily adjustment is very important in order to induce the compression force and Ilizarro technique. Thank you so much. We'll meet you in the next video.